thank the organizers for this wonderful introduction and all the present. I know that Paul Brand was a humble man, but I feel even more humble at the moment. It's a great opportunity and a tremendous honor for me to be able to talk to the memory of Paul Brand. He has been a leading star for me, and he has meant a lot for both my academic and my clinical career, and hopefully even more for the patients that I've been involved in the treatment of. So therefore, I feel that this is a perfect occasion to move on in a field that I have strongly been involved in, that is the reconstruction of the tetraplegic motor control of the hands and upper extremity. And it's since I've started with this type of research, I have been able to communicate with a number of dignitaries in this field, and I have only met Paul Brand one single time, and that was when he visited at UC San Diego in the beginning of the 90s, when he was collaborating with Dr. Richard Lieber. So I also think this is a time where I can reveal a secret. I know this is a super tough job to deliver a secret from the Nobel Committee, but when I was the secretary, the scientific secretary of the Swedish Hand Society in the late 90s, the Red Cross nominated Paul Brand for the Nobel Prize in Medicine. And as a hand surgeon and a representative of the Swedish Hand Society, I was the one who was going to write a support letter, a letter of recommendation for that nomination. And that was a very easy letter to write. Unfortunately, he didn't make it because the mRNA was awarded with the Nobel Prize in Medicine that year. I mean, it's not great to be a loser, but I mean, if you lose against that kind of competition, I think it's worthwhile. So that's you know, it's illegal to talk about the nominations, especially those who didn't pass. But I think this is the place where I can do it, and if somebody in the Royal Science Academy would kill me, I can live with that. So Paul Brand was unique in many ways, and he made me very enthusiastic about the biomechanics of the hand from the very beginning. And his way of communicating science, not only to the lay people, but also to the experts in the field, he managed to span that gap between difficult science and application in the real world. And I think he did it in an unbelievable way and made tons of students very, very excited about biomechanics. And he was humble, but he was also willing to share his ideas, and in the foreword of his different versions of the biomechanics of the hand, there's some sort of hint of what kind of person this is. Even without meeting Paul Brand, it's quite easy to read between the lines and understand that his generosity to the next generation, his way of looking upon human being as unique and with the right to have the correct treatment at any occasion, was really contagious to those of us who were introduced into this world. And I think that Adrian Flatt put it in a very nice way when the third version of the third edition of the clinical mechanics of the hand was released. By a typical quiet, persuasive manner, and writing succeeds admirably in making the case for basing the treatment of biomechanical principles. And that has been a leading star for many biomechanics, technical engineer, bioengineer, electronic engineer working near this type of science. And finally, I also would like to cite Paul Mansky when he made his memory lines in Journal of Hand Surgery some 11 years ago. And I think it's again showing personality and the person behind this very, very creative doctor. My personal connection is through my colleague and collaborator, Dr. Richard Lieber, professor of orthopedics at the Department of Orthopedic Surgery, UC San Diego, and we have been collaborating for some 25 plus years in this field. And that has been heavily influenced by Paul Brand's clinical mechanics of the hand. And I just want to show this picture, the graph describing the relation between fiber length and the cross-sectional area. It's basically representing the excursion and the force of different muscles. And Paul Brand managed to plot this in this way, and this is also developed and refined by Rick Lieber, and that's how they met each other. Anyhow, this has been a little bit of a Bible for me personally, because it illustrates so well where you can expect success in tendon transfer surgery and where you can be suspicious. This could be potentially a failure because you have chosen the wrong donor muscle for the recipient muscle that you're trying to replace. And we also learned in Paul Brand's books that usually it's the excursion, the amplitude that the muscle travels, that is much more important than the power. Because when it comes to the hand, power is a minor portion of the versatile tool that the hand constitutes. So that means that the fine motor motions, the manipulative tasks, are much more and better controlled by a donor muscle that is transferred to mimic fine-tuning of the hand. And again, this diagram very clearly shows where you can pick the right donors. So if you prioritize the fiber length, that is the excursion, you go to the right here and pick the donors. And for example, you can look at the flexocarpial naris FCU way to the left. It's a super strong donor, but it has very little excursion. So you have to think twice before you move it to a new function, etc., etc. So that brings us to the world of tendon transfer, and that also brings us to the world of tetraplegia, because that was how I first got in touch with this field, and that was through the professorship of Erik Moberg, who was in charge of the extremity surgery and later also the tetraplegia hand surgery in Gothenburg in Sweden. And he started more or less since he retired. But one thing that he was extremely impressed of was the communication that Sterling Bennell had with his patients, and how the first very primitive steps were taken some 50 years ago. And Erik Moberg, I never worked with him, but it's his professorship that I eventually inherited. So it's a special legacy also from that point of view. And that moves us into the patient. The tetraplegic patient is a patient who is paralyzed in all four extremities. That means there's not only the legs are not working, but the hands and the arms are affected somehow. Usually there are some remaining functions that we can take advantage of and upgrade to something functional and give functionality. And by functionality to the hands, the patient can, for example, move a wheelchair or a rolling bed or something that increases the freedom in his or her life. So that is a liberty thing. And the more sophisticated the patients become, the more they know about this field, the more they demand. And this is an example of a patient that we reconstructed both grip function, and you can easily see that his prioritized goals were very, very close to this skiing field, and grip function and power function was critical. Other patients do other sophisticated sports, and some patients even have ability to be extremely sophisticated. So this group of patients is not a group that we can just forget, put them in a nursery home and hope that they somehow society somewhere will forget them or hide them. They are extremely active, their brains are intact, and we have to remember that. The brains are intact and they have the full right to be part of the society. Most of the people with tetraplegia in Sweden are working at least part-time. So more than 70% are occupied in a part-time profession. There are even some of them who are doing full-time work, which is extremely impressive. When people come to us for consultation, it's usually because they know the field, they know other fellow patients, or they have read about it or found out about it on the internet, etc. So the selection is already there. They are in the driving seat, which is very important. But we also have to know that as a group, these patients prioritize hand function, as you can see. And this is based on a survey by Kim Anderson at UC Irvine, and she asked the question, what is the highest desired of a function that you would get back if you could choose? And this is based on 800 tetraplegics. And as you can see, about 50% said that it was the hand and arm function, and it's way higher than any other function. And that was a surprise to many people. For example, the walking need is not that necessary, because you can compensate. If you have hands and arms, you can go with sticks, or you can roll with a manual wheelchair, so you can get around. So walking or sexual function are way lower in this prioritizing list. There are also people who have very distinct goals with their life. This is a mother of three kids, and her #1 priority before considering surgery was that she wanted to be able to independently prepare breakfast for her kids before they went to school. And she did it. That is a very, very clear thing for us, because that, in order to meet those needs, it's quite easy to understand that it's extremely important to have an opening of the hand to come around different objects, as well as a grip function. So she's a very good representative of a daily life need that is so common. Other people can demonstrate a need to more independently be doing handwriting instead of a more clumsy dual hand control of the writing. And then when this is discussed to this patient, we have to say, well, in order to be able to have a good handwriting with fine-tuning and fine control, you need a triceps. You need to be able to stretch out and do your writing. And in fact, triceps is a key function for writing. I mean, that's how you move around the hand. And she accepted that, and we reanimated the triceps before we did the hand surgery. And luckily that is something that most patients accept, because they always talk about the hand function. They will need to get the hand function back somehow, but they don't want to hear about the triceps. I don't need the triceps. So there comes the communication, and this is also an education thing. We need to be able to communicate with not only the patients, but also the therapist and the physiatrist and everybody around the patient in their lives, so they can focus on the things that are important from our point of view. This also means that we are seeing the patient early in the rehab process. We want to come in within the first 3 months after injury or the cervical spinal cord lesion, to be a part of a team that is involved in the rehabilitation. We call our service surgical rehabilitation, because we are truly working hand in hand with other people in the rehab team. And we want to be part of that. We are part of that, as well as urologists or pulmonologists or plastic surgeons, keeping control of the pressure source, etc., etc. That means that we have a natural part of the rehabilitation, and the patient considers us as players in the rehab, not as surgeons coming in from outside, doing a quick job and leaving. That is not. That is the opposite, I would say, to our mission, because we want the patient to be a partner in the team of the rehabilitation. After all, it's the partner, the patient and the patient's family that are the security for the success. So that means that also the family members needs to be part of this. They may be able to make some changes on their own or with help of society or friends or whatever it is, to adjust the home to a more appropriate level. That also means that they take a certain responsibility, but we also are very, very distinct about this responsibility, that is the patient's responsibility in the first place, and that the rest is assistance. And assistance is needed when the patient and the family can communicate that in a way that is in an adult way, because it's very easy for a patient to become lazy if the support is too developed, and that is a backlash on that, becoming more and more dependent, which is contradictory to what we are trying to achieve with our surgery, which is independence and mobility and freedom. So that discussion has to be serious, and it has to be early, and that is why we want to come in early in the rehab phase. And with that said, I think that we can pinpoint the patient's prioritized goals very well, but we can also meet them, because one hand might be reconstructed in a power type of way, and the other in a more of a open hand fine-tuning way. But when you manage to meet the goals, this patient who was in a nursery home with no or very few relatives around and serious depression, wanted to come back to his old life, as they all say. He was extremely happy to comply with our rehab guidelines, and did a fantastic training. And yes, sure enough, he was back to this tractor, which was his life. So he was really happy with this. So the patient satisfaction level is the only single measurement that if we can prioritize, that is it. We have to measure others, things like strength and range of motion, etc. But that's more, I would say, that's more for the editor of journals than for the patient. Because this is what matters. It's the patient's perspective of the change after surgery. And we use the Canadian Occupational Performance measurement, which means that the patient describes the 5 highest prioritized goals and then report how well he or she can perform that and how satisfied they are with that before the surgery. And then after surgery, we go back to those notes. The patient had usually already forgotten that. Oh, I can't remember, that was that bad. But we do the follow-ups at 6 months and 12 months, and this is the mean result of what we're doing from the patient's perspective, which is the key point. So we end up around 6, and it's considered in international literature that increase by 2 points is a substantial improvement of quality of life. And we are well beyond that level. So that is extremely important to us, and this is how we check that we keep that level. Sometimes we have dips, and that has usually to do with patients that ask for too much, or we haven't been able to communicate exactly what to expect. And usually that's the relatively low injuries, so C7, C8, where they have a lot of remaining function and basically you're balancing the intrinsics. There you have to be extremely clear what the patient is going to achieve, and be super honest about that, and really question whether this is something that is necessary and what they would expect. One patient described this painting. She was a painter, an artist that was injured in a traffic accident while she was backing out from her driveway and was hit by another car, and she lost her ability to paint. And at that time she was 72 years old, and we operated her at 73 and reconstructed so she became one-handed again. And this is the painting that she brought at her 1-year follow-up. And she described this so beautifully when she was talking about, well, from being handicapped, I managed to fly again. And I mean, that's a pretty hard statement, I would say, from a 75-year-old lady who is in a wheelchair. That's fine if she think that is what she has achieved. We're more than happy, but we never guarantee flying. So if you look at Tetrahand surgery from a community perspective, it's interesting. We need to be able these days to convince those people who handle the money, the health authorities, the hospital directors, and all priorities that are made in a hospital and in society. So this is the Icelandic example, and I just wanted to show this because I think it's very interesting. This is not done by any doctors or the therapist or any people in the healthcare. It's done by authorities in the health department in Reykjavik in Iceland. Before they wanted to have a contract with our unit in Sweden to reconstruct their patient. So they did this test on 8 patients and then stopped sending them after 8 patients and wanted to wait for 1 year to see the level of assistance needed for each of these patients compared to prior to the surgery. And as you can see, it's only 1 patient who had no reduction post-operatively. And this could range. The number of hours could range from 724 service by personal assistants to 1 hour just coming in the morning and take the patient out of the bed or something. But overall, the reduction was 28% in need for personal assistance. And if you multiply that with X numbers of years, that in this patient population could be 50 additional years, we're talking about many, many millions of whatever currency, but euros, for example. So that makes the health authority really excited about this. Of course, they also care about the need for the patient, but sometimes even more so the need for the wallet. And that is one of our strongest arguments. So we have patients that improve, and we have sound finances from the society's point of view with this service. So therefore, we can move on and come up with some statements. For example, we believe that all patients should have the right to be assessed by an experienced hand surgeon, experienced in this field, and with a special connection also to the rehab unit. The surgery must mean a significant improvement of performance, not power, not some stupid range of motion that is measured on a regular basis by some whoever it is. It must be directed to performance, to ability in daily life. If it's not, we should not do the surgery. So this has been extremely clear that this is our goal. And we want them to have voluntary control, so we don't want to make a lot of fusions or make stiff sort of artificial robotic hands. We want to have them supple and movable and transferable. And this has made it possible for us to operate 57% of the patients in our country, because it's a standard. It's a standard consultation. It is a need for the surgery, and the patients are very, very clear about that. They are willing to undergo this type of surgery, and they're willing to invest not only the time, but also sort of sign up for a commitment to the rehab program, which is quite delicate. And we, in our type of surgery, we are encouraging the patients to do, actually we're demanding it, but to prepare mentally to start training the day after surgery. So I just briefly should tell something about some statements, because we have added on top of this measurements of the Canadian occupational measurement, we have also done some qualitative studies. And this is also an interesting arena that opened, at least to me, because I was extremely skeptical in the beginning. But on the other hand, if I'm trying to preach patient value, I also have to stand up for this and be willing to participate in actually driving the qualitative research. And some of these are extremely humbling. For example, that I don't need my assistant to do the SMS or reading the emails, handshake, and not being ashamed being in a restaurant eating. So all this is very, very human and very close entities, I would say. And I think I'm going to wrap this up and skip all the technical part, because that was not really the idea for this talk, in my opinion. I wanted to just reattach to Paul Brand and his mission, which was very similar, although somewhat different diagnosis, because in this field that is quite unique in the world, you have to be pioneers. And you have such caseload in this country, so you can really be players internationally and pioneers in India and a model for this part of the world, because it's quite unique. And you improve the quality of life for the patient, you increase their mobility, and you can stand up for Paul Brand's mission to provide a decent situation also for the handicapped people that many others don't really care about. So with those final words, I just wanted to thank again for this opportunity, and thanks for all the attention, and most importantly, I think that I can hand over this legacy of Tetrahand surgery in good hands in Vellore. Thank you very much.